what we're trying to do is we will talk about a slightly different subject and slightly more complex subject because it challenges our understanding and in fact, it took me a long time to understand and in fact accept the role of progesterone in the follicular phase for a completely different reason. And it's quite challenging because I think it looks towards the future in a slightly different manner. And it tries to explain how, once again, physiology works. And one of the things which we often forget is, I think we are so much focused on to understanding how IVF works that we forget to understand how basic physiology tends to work. And that's why once in a while, a researcher will come up with a phenomenal idea and will challenge our very concepts of understanding very basics of physiology. So what we'll do is we'll talk about this subject, which is the role of progestrogens to inhibit spontaneous ovulation during ovarian stimulation. So what are we trying to look for? And this was a very good review which was done by Antonio Lamarca. And there's another one which has come recently, which is again a very good review which is done. And so they call it PPOS, which is progestin primed ovarian stimulation. So let's have a look at what we have learned and what we have learned from luteal phase stimulation. In fact, if you start doing luteal phase stimulation, it changes the way you do IVF. And there are multiple reasons. One, it allows flexibility. And also, you remember as women age and as their AMH starts dropping, what we know is follicular recruitment starts varying, which means that everyone does not recruit in a follicular phase and a random recruitment occurs. So again, what do we know? Women recruit at least twice in their menstrual cycle. And that's important to understand if you're going to treat poor responders. And in some cases, they recruit 3 times. And what we have learned from the luteal phase stimulation is quite interesting. Is in luteal phase stimulation, the number of LH surges, spontaneous LH surges, are limited. And that's what people thought is, well, what happens if you use progesterone to inhibit the LH surge in a follicular phase? But one of the things you have to realize is that any introduction of progesterone as a pharmaceutical agent or in nature to a high level necessitates the use of freezing as its next tool. So you can do this provided you have an excellent freezing program. And if you have an excellent freezing program, you're more likely to be able to use this. So before we jump on to the pharmacokinetics and pharmacophysiology of this, let's go back to knowing the basics about agonists and antagonists. So what happens if you don't use any of this? And you'll see an early rise of estrogen leading to LH surge. Now, initially, pituitary suppression was done by the GnRH agonist, and later on, it was done by GnRH antagonist. So you compare it to nature, and GnRH agonists are more potent and have a longer half-life than native GnRH. So that's how they end up differing. And what happens in the early phase? And sort of as soon as you give a GnRH agonist, it binds to the GnRH receptors in the hypophysis, and a large amount of FSH and LH are released, and that is what we call as a flare. And so from there on comes our flare protocols. So what happens if you continue giving the agonist, and there's a prolonged use internalizes the receptor complex, so it decreases the number of GnRH receptors. So decrease of GnRH receptors is called as downregulation, and eventually decreases circulating gonadotrophins and prevents a spontaneous LH surge. Now, this is something which is important, and it's important for again, ovarian hyperstimulation, because what does it do? GnRH agonists and antagonists both bind to human luteinized granular cells. And thus they can also induce follicular cyst formation. The question is, why is it important? And if you have a look at this sentence again, and Many of us give the antagonist after an oocyte collection, which means that we say that will lower the chance of ovarian hyperstimulation syndrome. How? Your LH is already reduced, you've given an analog trigger, and then you're trying to act on the luteinized granular cells by giving antagonists. And what research tells us is that the antagonist does work on luteinized granular cells, and thus probably by giving the antagonist, we are probably getting the ovaries to settle down faster. Also, turn it the other way around, and if you continue to give the agonist in small portions after oocyte collection, you will see a pituitary rise of LH, but you also see the uh, uh, the ovary and the corpus luteum responding, the follicle responding. I'm just going to mute everyone. So again, the risk of functional cysts is higher and ranges from anything between 2 and 40% in older women when agonist is started in a follicular phase. And I say, when you run with the agonist, you are more likely to create a multifollicular growth in the beginning. And in women who have a high FSH, you also start seeing a higher incidence of functional cysts. Now, antagonists are slightly better and they have fewer complications. But again, there's a range of having a spontaneous LH surge with somebody on an antagonist will range from 0.34 to 38%. And again, where does it occur? It occurs in older women and in women with decreased ovarian reserve. So to give somebody an antagonist, the follicle comes to 18, 20, 22, and suddenly it disappears. And often you see it again, whom? Women with a low reserve. So let's go back to basics. And women with a low reserve will recruit faster. Why? Because the inhibitory aspect of AMH no longer remains. So what eventually happens is your AMH no longer holds the strings. So you're more likely to see these follicles recruit faster and also start going towards an LH surge faster. So while antagonists block LH surge in stimulated ovaries, antagonists are unlikely to block the LH surge in unstimulated ovaries. So if you give somebody who's coming through a natural cycle and is going through an ovulatory process and you decide, I'm going to give an antagonist doesn't seem to work on unstimulated ovaries. And it seems that antagonists work generally in ovaries that have been stimulated with gonadotropins. So let's go back to understanding the physiological role of endogenous progesterone in pituitary LH surge. So what happens? As soon as the estrogen starts rising, there is a negative feedback on LH production. As soon as the estrogen rises again, there's a positive feedback leading to LH surge. So again, what's becoming difficult is understanding how the effect of progesterone generally on the pituitary. And what we think is that its actions may be antagonist to estrogen, and it depends on the hormone ratio and exposure. And also what we have noticed is that the rise of progesterone, when does progesterone rise? And often, we say progesterone rise, often, we always have said that after ovulation, progesterone rise happens. No. So look at the analog trigger, and progesterone rise will always happen before ovulation. And in fact, what we know is even before LH surge, there's a rise of progesterone that tends to happen. Again, where can you use it? So if you have a more aggressive stimulation, more follicles, and larger follicles, you're going to see your LH rise much before, the progesterone rise much before the LH rises. And again, we have used this generally in oral contraceptives where you can use progesterone to block ovulation or to inhibit ovulation. So what happens if you give progesterone? And what we have noticed is it causes a dramatic modifications in GnRH pulse frequency. So if you remove the progesterone, the pulse frequency starts accelerating and starts the process of starting a period. And as soon as you add progesterone, the GnRH pulse frequency
Pulse frequency.
changes. When you enter, please mute yourselves because I think otherwise I have to go and mute you. Now, progesterone priming also slows LH pulse frequency. It augments pulse amplitude and reduces mean LH concentrations. Now, this is quite an old theory, and just have a look at it. When are we using this? We're using this almost 20 years down the line, where we are deciding that the role of progesterone. So as soon as you start giving progesterone at high doses, you're going to change the way the GnRH pulses start coming out. And this is almost close to 20 years after we've learned all this. So what are the types of progesterone? And you've got natural progesterone. So these are in order of what is closer to nature. And then you've got retroprogesterone. Then you've got medroxyprogesterone acetate, which is 17-hydroxyprogesterone. And then you have the 19 non-progesterone derivatives, which are often used in contraceptions. And they are estrogens and gonins. And then you've got spironolactone derivatives, which move towards being more androgenic. So which progesterone can we use? And if you have a look at this slide, then all progestrogens have a so-called progesterogenic effect. And they're selected on basis of what is the dose at which they can inhibit ovulation. So medroxyprogesterone acetate at a dose of 10 milligram a day will inhibit ovulation, while progesterone, you require a dose of 300. So if you have a look at this, you have different doses and you've got different progestrogens which can be used to inhibit ovulation. And there's a reason why we use medroxyprogesterone acetate. Now, how do you use it? So let's look at the normal menstrual calendar and the stimulation. So here you start stimulating with gonadotropins, and then you add the antagonist. Trigger, and then 5 days later you do the embryo transfer. In the progesterone primed ovarian stimulation, you start the stimulation with gonadotropins, and you add the progestogen with it. So let's say you're using medroxyprogesterone acetate, and you'll use it at 10 milligram a day, given every day. And what do you need to do? You need to either freeze the eggs or you need to freeze the embryo. So from a protocol aspect, it seems very simple. So you just started with stimulation, unlike the antagonist. And what you're aiming to do is you're aiming to continue it till the day of trigger. And at night, you can either trigger with HCG or GnRH agonist, and both will work. So the question now comes up is, can exogenous progesterone replace the antagonist and the agonist? So this review took 10 studies and looked at all 10 studies, and these were almost 2,600 patients in 10 studies, and medroxyprogesterone acetate was used. It is slightly more androgenic. And the most important thing is it does not interfere with the measurement of endogenous progesterone production. You start MPA from day 3 of menstrual cycle, 10 milligram a day, and continue it till the day of trigger. Now, the oocyte difference is not significant, and what they noticed is on the short protocol, they had more oocytes. Quality of embryos did not show much difference, and implantation rates when they were initially replaced were quite similar, and there was no evidence of congenital abnormalities. And these were the multiple studies which were taken, and if you see, a large majority of them have been medroxyprogesterone acetate. And generally, if you have a look at their success rates have generally been in a range of 40s to 50s in pregnancy or live birth rate. So, and in fact, it seems that pregnancy rates continue to be good. And again, it was tried in PCOS, same protocol of starting it along with stimulation. Fertilization rate and ongoing pregnancy rates were higher than control group. So what dose do we use, 10 milligram or 4 milligram? Now, in 1984 was the first time this was used. And I believe that this would have been used during when they were doing dose planning for contraception. And they detected that 10 milligram of MPA inhibits ovulation and 5 milligram did not. But recent times, they've realized that even 5 milligram did not show additional rise of LH surge and viable embryos similar to two groups. So the next question is, what is the rate of LH surge? That's important because if you're going to counsel your patient and say, I'm going to give you the PPOS regime, you also want to tell them what is the chance of failure. And in a study where they used a mild stimulated versus natural, the LH surge took place in about 1% of cases, very similar to an antagonist, and premature ovulation took place in 2% of cases. Compare it to a natural LH surge in a natural cycle, where it's 50%, and premature ovulation of around 10%. So the question is it always so good? And suddenly you come across another trial that suddenly starts questioning, and that's how research goes on. If you read a paper based on one trial and come to a conclusion, you're more likely to be wrong. So here it was a non-inferiority trial of MPA versus GnRH antagonists, 252 site donors, and those who had medroxyprogesterone acetate had a worse pregnancy rate compared to GnRH antagonists, and biochemical pregnancy rates were lower, ongoing pregnancy rates were also lower, but live birth rates probably came closer, but I wouldn't call that close. So what it does tell us is that we are getting to a point where I think we understand how it works, we know it works, and we think that oocyte quality, embryo quality is maintained, but there will be cases in which this may not happen. So can you use other progesterones? And yes, you can use utrogestan at 200 milligram a day. And again, Zook et al. Did these studies where they looked at giving utrogestan. The rate of ovarian hyperstimulation was similar. Fertilization and viable embryos were higher in the study group. And doses of around 100 milligram a day were also quite effective. And again, why is NPA preferred? Because you can measure progesterone and that does not interfere with medroxyprogesterone acetate. Now you can use dydrogesterone too. And again, what you notice is that the results were similar in oocytes and embryos. So what is the advantage? And the advantage to a large extent is that we think progesterone seems to work in suppressing LH surge in a follicular phase and does not seem to affect oocyte numbers. And one of the questions which we've always asked is, does prolonged progesterone exposure have any impact on oocyte? And I think we're still not certain. But again, remember, all this evidence that comes up on fresh cycles and on high progesterone on day of trigger and the impact of endometrium. Once you freeze embryos, the question is, how often do you freeze embryos with high progesterone? And in the frozen cycle, the results seem to be much better. It is more friendly, and there's no doubt, because you're taking away one injection completely. And it's important to realize that you need to do a freeze-all in this case. Where do you use it? And you can use it in donor stimulation. You can, again, there certainly you're lowering the cost. In fertility preservation, in PGTA cycles, in double ovarian stimulation, and those are the non-conventional protocols, and in IVF in women with a high risk of ovarian hyperstimulation syndrome, where again your risk of having OHSS is reduced. The next question now comes up is, do you really reduce the cost? And that's where there's a huge debate. And you'll say, well, with an antagonist, you would reduce the cost, but where does the cost increase? Freezing and frozen replacement. So probably the costs even out. There is also a weakness because we think that once you suppress with progestrogens, it is very likely that you are going to see a higher dose of gonadotropins used. But at the end, what you have to remember is that this seems to work. And if you're planning to use a donor cycle, lower your costs, I think this is worth trying. Equally, which other drug would work if you want to lower your costs and don't want to use the antagonist, which has been proved that that's clomiphene. So if you use clomiphene right from day one to trigger, the risk of spontaneous ovulation is about 2% or so, which is slightly worse than that of an antagonist, but it's more likely to work. So where would I use it? Would I use PPOS? And I think yes, if in case somebody where I have to reduce the cost of drugs significantly. But otherwise, I tend to use a clomiphene to do very much the same thing of preventing the feedback mechanism. So that's in short about uh, you know a concept that is very different, very challenging, and something which I believe we can use for some of our cycles. And evidence is there that if you're doing a donor cycle and you want to bring down the costs without affecting the results, then I think it is worth giving this a trial and see how it works. So if you have any questions, then you can pop it in the chat or ask. I muted all of you. Gosh, have I been so clear and that everyone's understood or everyone's going to sleep? Oscar, are you sleeping or are you awake? I muted you. No, it doesn't seem so that from all the studies done, MPA does not seem to have an effect on the growing embryo. Also, because they're frozen and they've looked at the uh, abnormalities, uh, doesn't seem to have any effect. So, yes, you can do a fresh transfer, but you have to remember that there'll be a proportion of patients who will react quite badly to clomiphene on the endometrium. So I tend to use it generally in my poor responders where I can give it a trial and see if it gives a multifollicular growth. So if you give clomiphene over a longer period, you're more likely to see multiple follicles because it gives rise to more sustained FSH. But can you do a fresh transfer? Technically, yes, but I would believe that results may be lower. Yeah, I think the talk is recorded, so it will go back onto the initial. Uh, Generally, if you're using the antagonist, so in my practice, how often would I use the progesterone primed? I don't think so. I think with the I'm more used to the antagonist. So if I have to delay the antagonist, I tend to use clomiphene. So I will usually continue clomiphene till day 10 before I add the antagonist, just because I'm a bit more scared. But that's it. But otherwise, I think an antagonist also does equally well. Clomiphene does equally well. I think Sachin can't connect.
So why has it not become so popular then, Anil?
I think it's probably
If
because
it
you
is
have to
so
face
good, then
everyone.
why does it not work? I mean, why do people not use it very much?
I think there are two things. I think a lot of us are still not convinced, and that's probably. So if you remember at the meeting in where is it, in Budapest, I think this talk was done, and there was a general reluctance from a lot of people because I don't think we understand that the very concept of giving progesterone a follicular phase is a bit confusing. Uh, and I think our evidence of using antagonists seems to be, I doubt if we'll use it, but it's a good concept which challenges the very basic of our understanding of physiology. Rectal cyclogest and a difference to transnational. Oscar, I don't know what you mean by, you mean transvaginal? Okay, okay. No, I think there's a paper which I've just been reading, and again, it's by Peter Rumeden, and what he's trying to do is trying to combine vaginal and rectal, and I think it works. They work in different ways, and using a combined dosage does increase progesterone levels. But it's just one paper which has come up, and Peter Humedin often is very good with with his research on luteal phase. So I think it's only a matter of time that we'll know a bit better. But in a frozen cycle, probably we think we need to have high progesterone levels, and that's where the evidence is. Will BMI affect the dose? Probably yes. I think like all drugs. Uh, does it affect the dose of HCG? Yes, it does. But antagonists probably no. Absolutely. I think that's what we said, that when you use MPA, you are you don't really save costs because you end up freezing embryos and then using a frozen thaw cycle. So in fact, you're going to have, if you're somebody who does a lot of fresh cycles, you're going to increase the cost to the woman. There's no doubt about it. But its only advantage what I'll see is that if you use HCG, which I feel that it's very dangerous to use HCG in PCOS, and if you have used the PPOS protocol, your risk of overstimulation is slightly lower, and that's because prolonged LH activity is prevented. But I think it's quite a dangerous thing to give HCG. I think it's a complex subject, isn't it? And that's probably got everybody thinking, where would I use this?
Well, I think, Anil, why it hasn't picked up very much, apart from not just being a concept that doesn't fit into very many people's brains, but I think it's also that if the data shows that your requirement for gonadotrophins is going to increase, or the days you stimulate is going to increase, then what is the advantage against antagonists, isn't it?
Absolutely.
Patient is doing one injection, might as well do two. So I think that's probably where the issue might lie. Who knows?
And also, I think it took us, if you remember, in the 1990s, we
Yeah,
were so reluctant to use the antagonist.
yeah, well,
And it
1990s, you're talking about, I'm talking about 2020. There are 1/3 of clinics in UK still do not use antagonists.
so now to ask people to use progesterone, even if it's just convincing good evidence about physiology, it's going to be very difficult.
Yeah.
I think
Somebody's saying, will they be able to do dual stimulation with this protocol? Well, yes, you can.
you can just continue giving the drug throughout, and you can do a dual stimulation. And I think that's where I think its role is present. And absolutely.
And again, we talked about dual stimulation so much, but the real genuine area where dual stimulation may make a difference is cancer patients. Apart from that, I haven't seen a patient who is that anxious that she wants to have 2 egg collections within a month. Who wants to have 2 egg retrievals in a month? I don't think people do, unless it's a cancer patient. So I can understand the whole luteal phase stimulation and 1 egg retrieval, but 2 egg collections is a bit too much. But I don't know.
Yeah, with Indra, yes, if you want to make it work, you have to start the antagonist, the NPA with stimulation. As soon as you give it after day 5 and they've looked at it, it has a higher rate of LH surge and it doesn't seem to work. So you can't use it like an antagonist. You have to use it right with the start of stimulation and not on when follicle size is 13 or on day 5.
But also, Dr. Indira, if you're using antagonists, don't wait for follicle size to be 13 or 14. And again, we have discussed this throughout various talks, that just fixed protocol of starting on day 5 with antagonists is fine. And progesterone, perhaps you start even on day 1, as soon as the stimulation starts. So don't wait for 13 millimeter. You will encounter more premature luteinization.
So that was a short talk, and I think it's good to challenge something. I think Sachin wants to present fibroids and assisted conception. And that's a very good topic to go for. I generally prefer to keep away from that because I don't think we know the right answers for many, many things. So thank you very much.